And now we're going to talk about postpartum. What do we do now that the baby's here? We have many objectives in this unit. You can read through all these, but bottom line, we're going to cover the physiological changes that will go through the mom's body after delivery, how we as nurses can help promote health of the mom and the baby, get them ready for home care. Think about the psychological aspects, not only for the mom becoming a new mother or a new mother of more children, and her partner as well, and what to assess, what factors will increase a woman's risk for postpartum complications, and what are the danger signs that we need to be alert for. Additionally, we're going to compare the difference between women who deliver vaginally to those who deliver via C-section. There's similarities certainly, but there are some differences when a surgery has been involved. Bonding and attachment, what inhibits or enhances the attachment process, and what is the nursing management for the woman during her family during the postpartum period, and the role of the nurse in promoting successful breastfeeding, and what health education is needed beyond the hospitalization. In postpartum, it takes about 6 weeks for the body to return to the pre-pregnancy state. Now, having said that, that is a minimum length of time, okay? It can take a lot longer for some women depending on their delivery experience. It's a critical transition period for the woman, newborn, and the family, both physiologically and psychologically. An alternate definition would be that changes in all aspects of a mother's life that occur during the first year following birth of a child. And this 6 weeks, as I said, is a minimum. It's going to take a good year for the mom to feel like she's back to her old self now with a baby. But it took me a good year before I felt like Diane was back. Okay, so 6 weeks is a minimum. This lists the risk factors for postpartum complications, and you'll see there's kind of two lists there, one on the left, one on the right, the postpartum infection and postpartum hemorrhage. These are the two most common complications in the postpartum period. It's important to know what puts the woman at risk for each of these, and for the postpartum infection, you can probably figure some of that out if they had surgery, the C-section, or if they've had a tear or a episiotomy that needed to be repaired. That's a surgical wound that has a potential to be infected. Are they a diabetic? That increases infection risk right there. How long was their labor? The longer the labor, the greater the risk of infection. Did they have the Foley catheter? And how long did they have it in? Anemia, having a low reserve to deal with complications, and then the premature rupture of membranes. If you remember, if they've been ruptured before labor starts, they have an increased risk for infection. How many times has a woman been checked vaginally? Those women, if they were in the labor a long time, they're going to have more vaginal exams than someone who was in labor a short time. So they are at increased risk because of every time we check a woman, we increase their risk of infection. Has the provider had to go inside and manually remove the placenta, or did it just fall out? If they had to go inside to get it, again, that's a risk factor. And certainly if they have compromised immune systems, they are at greater risk of infection of any kind. Postpartum hemorrhage on the right here. These are all the risk factors for having a hemorrhage afterwards, and we've spoken about most of these, I think, in our complications of labor and delivery slide. Those precipitous labors, those are the ones where the uterus just pushed it out so fast, and it may not have time to just really contract up afterwards. And then uterine atony, whether it's because of an over-distended uterus due to more than 1 or 2 or 3 babies in there, or if the baby was excessively big, that's going to cause atony of the uterus. Did the placenta have a problem? Is it a previo, or did it have an abruption where it ripped off the uterine wall? Any operative procedures? Now, having said that, the surgery, doing a C-section, those women actually will bleed less than a vaginal delivery because the surgeon is able to clean out that uterine environment literally with wet laps, sterile wet laps. They wipe it out so they can see that they've gotten all the placenta. So actually, operative procedure may reduce the risk, but anytime you do surgery, we have a risk of tears of blood vessel tearing. So there's that. If the placental have parts of it retained, placental fragments, and POC is products of conception. If they've been left behind little bits, they will cause hemorrhaging. How long was that stage of pushing? When it's over 30 minutes. I'm sorry, not pushing, of the placenta. I'm sorry. How long was did it take for the placenta to come out? If it happens within 30 minutes, you're probably pretty good. But then if it prolongs and it takes over 30 minutes, there's an increased risk of infection because the doctor may have had to put his hand inside or whatever. We talked about multiparity, more than 3 births that are closely spaced especially, and then uterine overdistension for whatever reason, anything that made that uterus bigger than a non-overdistended. Someone who's normal pregnant versus large baby, hydramnios, anything that can cause a more distended uterus will put her at risk for postpartum hemorrhage. It's hard to show an assessment of the amount of bleeding and what's normal and what's too heavy, but this slide does try to do that a little bit. Initially after delivery, within the first couple hours, they're going to have heavy bleeding, kind of like a heavy period. They may get blood clots, very normal, and so that would not be unexpected to have a lot of bleeding. You get up to the bathroom, the blood has pooled in the uterus, so they'll get up to the bathroom and all of it falls out. So initially that's not of a big concern, but over the hour or two right after delivery, that bleeding should slow down. The other thing that we need to be watching for is that the fundus, the uterine fundus, is tight and firm and contracted down. If that fundus is boggy at all and not contracted tightly, it will just keep bleeding. And I do believe in simulation or scales, probably simulation, you're going to experience feeling a tight fundus versus a boggy fundus. It's hard to kind of recreate that on a mannequin, but we do try. The guideline for uterine involution, involution meaning it going down to its pre-pregnancy size, it's going to go down about 1 centimeter a day, and you can consider that as 1 finger breadth a day. Right after delivery, the uterus is going to be right at the belly button. Okay, I'm going to try to draw this. You know me and my drawing. I do like to have fun here. So we got that. She's delivered. Here's her belly button. So right after delivery, the fundus is going to be right about at the belly button. You'll feel it really firm there. The next day, it should be 1 finger below that belly button. I can't do it. I can't do it. I'm not coordinated enough. Kind of 1 finger below. And each day it should drop 1 more finger breadth until it's finally below the symphysis pubis and you can't feel it anymore. They're home by then. So day 1 after delivery, if you palpate that fundus and you find that it's 1 finger breadth below the belly button, you're in she's in a normal involution state. However, if you palpated her at one day and that fundus was up above the umbilicus, you got to wonder what's doing that. Is it bleeding, or the more likely reason is they have to go to the bathroom? So if you find that the uterus is up above the belly button, up above mom's umbilicus, have her go to the bathroom and then come back to bed and recheck. It'll probably be where it's supposed to be, unless something is wrong. All right. This involution occurs by contraction of the muscle fibers, and they're going to have afterbirth pains. They're going to say, "Oh my God, I thought I was done cramping." No, this happens for a couple days as that uterus shrinks down, and these after pains get worse with each pregnancy. So the more kids they have, the more afterbirth pains they're going to get. And that's because, if you remember, that uterus the more it gets pregnant and delivers babies, the more likely it is to lose its ability to contract down. And so this after pains is it really working hard to do the job that wasn't quite so hard the first time around. The lochia is what the discharge is called. It's pronounced lochia, and it takes about 3 to 6 weeks to completely resolve. It does change character in certain days. And you'll look at the rubra is that dark red. That's what you're seeing kind of here is the dark red rubra. It may have some clots. These clots should not be larger than the size of a quarter. But if they have small clots, it's not a big deal. And that lasts for about 3 or 4 days. After that, it changes to what's called serosa, which is not over here. Serosa is the more fluidy bloody, okay? It's thinning out. It's more like clear fluid with some bloody stuff in it. And that lasts from 3 days up to about 10 days, 2 weeks maybe. And then it will change to alba, which is the yellow-white discharge, which is indicative that the whole uterine wall has healed. The bleeding is evidence of the place where the placenta was growing, healing, expelling blood and healing up. So as that heals, you'll get less and less thick blood, and eventually it turns yellow-white. Over here, these pads over here are showing you the difference between heavy amount saturated peri-pad within an hour. That would be classified as heavy, and then compare that to the moderate, and then to the light amount, and then scant. All right. This after delivery, right up after delivery, would be normal. It would not be normal the next day. All right. It should start to, get less and less. So that's that on the bleeding afterwards. The cervix, the internal os, that's the part that actually dilated. Well, the whole cervix dilated, but the internal os is the part that you feel when you check a cervix. That's what that part is, and it returns to pre-pregnant state. And the external os also changes, and it changes in that what used to be a little circle now looks like a little smiley face on the cervix. For example, someone who would come in for a pap smear who's had no babies. Here's the cervix. This is like Etch-a-Sketch. That's what it reminds me of now that I think about it. This is the cervix of someone with no babies, and she has a little circle, os, O-S. That little spot right there is where we get the pap smear. We put the swabs and sticks inside there to get cells from that os. So that's a little called a nullip cervix. This person has never had a baby. What happens once you have a baby? Guess what happens? It gets like a little smiley face. It really, really does. And so this patient, when we look at her in the office at her cervix to do her pap smear, again, the pap smear is being done right in there, inside that little smile. We know she's had a baby. And yes, in my career, I've had women who say who have declared no children on their admission, history form, but I see a smile. And so I know darn well she's had a baby, but do I confront her on that? No, not unless I needed to know because she was pregnant. Routine GYN exam, her business. I just do my job. Job won't change. But in OB, my job might change because remember, someone who had a baby already, their next labor will go faster, and it also gives us indications of historical aspects of her ability to deliver a healthy baby. So we encourage vaginal rest for at least 6 weeks. And honestly, the real person in charge of this is not the doctor, not the midwife, certainly not the husband, but the woman who had the baby. She is in complete control over when she wants to use the vagina again to have intercourse, because everybody is different on pain and how it heals. So we can't really tell them when to have intercourse again other than to say at least wait at least 6 weeks. Okay? The perineum, that pelvic floor, will get a little weaker, and if they had a 3rd or 4th degree tear, those are ones that go into the rectal muscle, then they're going to take a much longer time to heal. We need to talk to them about contraception because ovulation is going to return, and we don't know when. Breastfeeding is not a birth control method. So if someone has been told you cannot get pregnant when you're breastfeeding, that's a lie. You can. We call those, I don't want to say what we call it. It'll probably sound whatever. We call them Catholic twins because I have Catholic twin friends. They were born 11 months apart because breastfeeding didn't work for their mom. Bleeding and hemorrhage medications. We got oxytocin, which now is made by the body. So when mom breastfeeds, the stimulation of the nipples will cause her to excrete oxytocin. But we also almost routinely, almost every delivery, will be giving Pitocin in that IV to help contract that uterus and give it a boost of cramping and contracting to minimize the risk of postpartum hemorrhage. Right after the placenta comes out, we turn the pit wide open or put the pump on the highest speed possible. But I used to just open the pit up, let it run. You cannot overdose a newly delivered woman on IV fluid or Pitocin. Well, you can, but it's going to take many bags. You're not going to use that many bags. But we do want to monitor for fluid overload, and especially in what patients do you think would be at higher risk for fluid overload? Think of those preeclamptics, the ones that have the risk of fluid buildup in their lungs anyway, okay? So those you'd want to watch closer, but usually you cannot overdose a woman on too much IV fluid and Pitocin with a bag or two. Methergin, I can't even say that. The Methergin is very commonly used. That is the second go-to medication that almost any provider will use if the Pitocin's not doing the job. If the Pitocin is causing that uterus to be firm and tight and clamp down well, that's all we need. But sometimes the uterus does not respond enough to the Pitocin, and so we need to give them Methergin, which is given IM, and that provides a different mechanism of action, which allows that uterus to clamp even more. This is vital, though. If someone says give her Methergin, you're going to go get it, but before you give it, you got to take the patient's blood pressure, because you can cause them to stroke. Their blood pressure will go sky high because of the way the Methergin works. So it's constricting all the blood vessels really fast, really hard. Well, guess what? In hypertension, those blood vessels are already super constricted. So if you constrict them even more, you're asking for trouble. So what we would say is, doctor or midwife, her blood pressure is 180/98, and they would say, never mind, no Methergin for you. Let's go to one of these two. There's going to be some people that start with Cytotec. That's the third one. Others will use Hemabate. Let me talk to you about each one a little bit. Cytotec is usually, it says oral, but it's usually given rectal. I've never seen it given oral because that's with their stomach and all that. We just don't do much oral medication for that. So they're going to put 600, 800 micrograms of Cytotec in the rectum to help control the bleeding that way. That is usually the third thing, the third potential step. This would be one, this would be two. If Methergin works, you're done there. Or if you can't give Methergin, okay, Pitocin, if it works, you're done. If it's not, then give Methergin, unless they're hypertensive. If giving Methergin works, you're done. Or if they can't have Methergin because of blood pressure, then they go to more likely Cytotec. All right, that's usually the third drug. And that leaves Hemabate for number 4 option. And the reason we put that at number 4 is one of the side effects of Hemabate is, and it's an IM, it's an IM medication, is it causes complete contraction, relaxation, and contraction of the whole system. So bottom line, they poop everywhere. Stool just comes rolling out of them. Okay, and I have seen it roll off the bed and onto the floor. So much comes out. So it is not only messy, but it's embarrassing for the patient. I would always warn the patient, look, I've got to give you this medicine. It's going to cause a lot of diarrhea to come out. You may want your family to step out in the hallway for a while. I would let her know so she can make a decision. And let her know that this is going to happen. And our job as nurses, of course, is to keep her as clean as possible. Just keep on it. So Hemabate is generally not the preferred drug. More people are going to want to go down here to Cytotec because of the side effect. The nursing assessment for postpartum hemorrhage, anticipatory care. Know your patient. Know those risk factors that we covered in that one slide. If she had an 11-pound baby, she's at higher risk. If she had twins or multiples, she's at higher risk. If she had to be induced and was in labor for a long time, she'll be at higher risk. So know those risk factors and realize I got to watch her a lot more closely. Okay, we don't trust these women. Make sure you know whether or not you can give a blood transfusion if you need it. Hopefully this consent was signed on admission. There are some religious people that will not get a blood transfusion, so you need to know who those people are and come up with plan B, you know, how to take care of these. And that should have been discussed with the patient, with her physician talking to her prior to her even being in labor. So hopefully that had been taken care of. And then if they go into the postpartum, we just really watch them closely in postpartum and educate the patient. Tell them when to call me, okay? You know, if you have this or this or this happen, if you get clots larger than the size of a quarter, if you get up for the next 3 times and every time you're gushing out a lot of blood, let me know. I need to see it. I need to evaluate you, okay? Do frequent checking on them. They can be deceivingly normal and then all of a sudden crash. So never trust them, even if they're sitting there breastfeeding. That doesn't mean things can't happen. Hands-on assessment, initially we do right after they deliver, we do that fundal check where we palpate where the uterus is and how firm it is every 15 minutes for the first hour. Some units, some hospitals go for 2 hours doing that. So know your unit policy. Once they're stable at 15 minutes, then you can go to every hour until they're transferred up. I say up because that's where postpartum is, where I work, but transferred to the postpartum unit, and on the unit they do their initial assessment fundal check as well as every 4 hours afterwards, and then it becomes an every 8-hour check. The hands-on assessment consists of palpating the uterus, looking at the pad, seeing how much blood and describing it, how many clots are there, and then we would weigh the pads if and this would be most likely to happen in labor and delivery, right after delivery. If you have a patient who's bleeding heavily, start throwing the pads in the bathtub to collect so that you can weigh them and determine an estimated blood loss much better. It's hard to evaluate blood loss when it's a subjective thing unless you can weigh it. Now you don't have to weigh somebody's normal, but if you realize, oh my God, she is just pushing out stuff constantly, put those pads, the blue chucks pads, whatever she's got, towels, put them in the bathtub to collect until you have time to weigh them. And then if you're concerned, you want to call the provider for assessment. There's different types of bleeding, and I don't know if the next slide is going to do that, so let me talk about that real quick. There is the bleeding from the uterus, which we went through as the rubrilochia, which becomes serosanguinous type, and then it becomes the alba. You remember that. However, if you find that your patient continues to have a constant trickling of bright red blood, just constant, the fundus is firm, if she keeps bleeding, kind of trickling constantly, and the fundus is firm, the problem is not the uterus. It is something else, and that something else would be some type of a tear. If you cut yourself, accidentally cut yourself, what kind of blood do you see coming out of that cut? You see kind of the bright red, and it doesn't come out in clots. It just comes out like drip, 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 or pour, pour, pour. Same with vaginal or cervical or labial tears. They will just drip blood, and they are, again, you're not going to get clots. It's going to be bright red, and it's going to not be related to the uterus because the uterus is firm. If that uterus is firm, that is not the problem. You have to identify what's really bleeding in order to have the correct treatment. So those medications that we talked about to have that uterus contract are not going to help postpartum bleeding that is due to tears. Tears need to be repaired by the provider. The nursing interventions we do to promote comfort, a nice cold ice pack to the perineum for the first 12 to 24 hours. My bottom line, I would tell patients, keep ice on your bottom until lunchtime tomorrow. That covers pretty much any hours of time, and they don't have to remember a time. They just know, oh, at lunch I got to stop ice and switch over to these nice warm water sitz baths. Okay, keeping ice on the perineum, it decreases swelling and edema, and it increases comfort because it kind of numbs it. But beyond that initial 12 to 24 hours, all you're doing is increasing the risk of freezing the perineum. I honestly have seen frozen labia because the cold pack was too cold on too long. So watch that very, very closely, that they aren't having actual labial freezing, because it's because the labia will swell. They'll be full up with fluid, and so you can more easily freeze, believe it or not. So really be careful for that. After the first 12 to 24 hours, we want them to switch to the sitz baths, because sitz baths are warm water soaks that help promote healing, and that's what they need after that first several hours. Okay. Some women will benefit from topical preparations that we have lidocaine, different types of canes, medications to use on top, and then analgesics, oral analgesics to help with some of that pain. We want to assist them with elimination and reassure them that you may not have a bowel movement for several days. Don't let that be a worry. You know, you don't have to have a bowel movement before you go home, because that may not come until day 3 or 4, and generally vaginal deliveries will go home on day 2 or 3. They are given stool softeners every evening to help keep it soft. Have a diet that's healthily going to promote bowel movements. It's kind of scary having the first bowel movement. I can tell you from experience, because you're not sure what's going to hurt down there. So they need a lot of reassurance that you're going to be okay, and preventing constipation is the biggest thing to do to prevent the problem. Promote activity, rest, and exercise in balanced proportions. Drink lots of fluids, especially breastfeeding moms. Breastfeeding moms will use all their fluid will go to the breast milk, leaving very little for the colon. So they need to drink a lot of water, a lot of water. Doing some Kegel exercises afterwards to help prevent stress incontinence, how to take care of themselves, how to clean. Every time you go to the bathroom, you should clean your bottom with warm water. Don't use soap on it for a few days. Just clean with warm water, and then go to the bathroom frequently. They should go to the bathroom every 2 hours initially. And that is because when they're pregnant, that bladder, the baby's been sitting on the bladder, and they have to pee all the time. And they don't go a whole lot because the baby doesn't let there be much space in the bladder. Well, once the baby's out, that bladder will just fill right up, and they can't even feel it because there's no pressure on it anymore. So it's important on someone who's newly delivered to make sure she understands, even if you don't feel you have to go, get up and go every 2 hours. And I actually would say go it's like 4:30, all right, go to the bathroom, and now every hour on the even, like 4, 6, 8, 10, get up and go to the bathroom, or the odds, whatever you want to do, but give them even or odds. That way that's going to click more with them than, oh, it's 10 o'clock. It's like, oh, it's an even hour, I got to go. Ensure their safety, especially with their baby, that the baby is kept safe, and then we need to talk to them about sexuality and contraception at some point. Is the following statement true or false? You should be able to answer this now. After birth, the cervix returns to its pre-pregnant shape. Your answer is false, because it goes to a smiley. It goes from circle to smiley. All right, cardiovascular, what happens there? The cardiac output is high in the first few days postpartum, and it returns to normal within 8 weeks. Now remember, pregnant women have 50% more blood volume when they're pregnant, and once the baby's out, things start shifting, and they really start peeing a lot. That's another reason to get up to the bathroom every 2 hours, because you are making more urine, and you can easily get over-distended bladder. Their blood volume will return to normal within about 4 weeks. The vital signs will get back to kind of normal within about 6 weeks. They are at risk for deep vein thrombosis, and because of the clotting, increased clotting that's there during pregnancy to prevent us from hemorrhaging after we deliver. That's why our clotting gets a little stronger in pregnancy, so we don't bleed out. But then it puts us at risk of these other things like the thrombosis. That will resolve in about 3 weeks, and then the hematocrit will stabilize or increase. Now, if you remember, the hematocrit on a pregnant woman is going to show less than on a non-pregnant woman. And knowing what you now know about the blood volume in a pregnant woman being 50% more, you should be able to figure out why the hematocrit will look lower. It's just the fact that there's more volume for normal hematocrit to live in, and so volume-wise, it seems to be a drop, but it's really quite normal to have, say, a hemoglobin. We'll look at that of 12 when we're not pregnant is great, and it can be down to 10 when we are pregnant, and that doesn't mean she's sick. It means she's got a lot of water, fluid, making it look less, and that hematocrit does the same thing. All right, here's a question you now should be able to answer from the information you just got. The drop in maternal blood volume after birth leads to a similar drop in hematocrit. Is that true or false? Will the hematocrit drop when the blood volume drops? False. It's going to rise, right? Because there's less volume there, and so it's going to appear to be a higher hematocrit. It'll be the same amount, it will just appear higher. All right, here's some pre-pregnancy lab values in the non-pregnant first, second, and third trimester for your referencing. Of these, this is what we were talking about, the hemoglobin in a non-pregnant 12 to 15. You see how it drops, but it's still normal in the first trimester. It'll get even less here and kind of stabilized in the second and third trimesters. But it drops, but it's not dropping because she's sick. It's dropping because she's got more water, more fluid in her blood vessels. The glomerular filtration rate and renal flow increases after delivery because something's got to help all that water get out of there, right? So the postpartum diuresis is a real thing, and they will pee and pee and pee and pee and pee for a couple days, okay? The voiding sensation is affected by any lacerations. They kind of don't want to go and burn because they burns. Okay, so they're a little reluctant to let urine hit the lacerations. There may be generalized swelling and bruising of the perineum and tissues surrounding the urinary meatus that can cause some tenderness and I just don't want to do it. Hematomas would be interfering. That's just because there's in pain down there with the hematoma swelling up the labia. It causes big and firm hard labias. Those are painful. Decrease in the bladder tone due to, say, epidural. So they're not going to feel the urge to void as much. And then and it's kind of summarized here, but bottom line, you don't have that baby pushing down, so you lose that stimulus of, I gotta go. The GI system will quickly return to normal. You get relief of pressure on the organs, so thank God. Nothing's pushing on all my bowels. Their bowel tones may be decreased for a few days, but they should still have bowel sounds. It's really important to assess the C-section patients for bowel sounds. Getting these patients up, especially the C-section ones, as soon as possible after delivery is really important to prevent peristalsis and severe pain due to constipation and the inability to pass stool. That alone's worse than labor, I think. So get these patients up and moving to get this peristalsis to come back. This fear is big. It's a real fear. I mean, you're like, it's going to hurt down there, but they got to work through it. And hunger and thirst occur due to not being able to drink before delivery, and they basically ran a marathon to get the baby out. So they're hungry, they're thirsty more. Yeah, they're both. They're going to be really hungry and really thirsty. So give them a lot of fluid and feed them good protein foods. Musculoskeletal, these joints will return to the pre-pregnant state, except for the feet. They stay bigger, weirdly enough. Women commonly experience fatigue and activity intolerance 4 weeks after giving birth. Everybody's different. Everybody's individualized on that. You cannot say that this person and that person are the same. This person may do well, and it's so many variables. What is her red blood count? What was her, was she anemic? And then how long did she push? There's a lot of variables. So fatigue is real common, and we can't ever judge anybody because they're having a hard time. The abdominal muscle tone is diminished after birth, and so they need to do some exercises to get those built back up. Respiratory system, wow, they can start to breathe more easily. All the volumes return to their capacity within 1 to 3 weeks of birth. So that's really awesome. Safety during ambulation. The first time these women get up after having a baby, if they've had an epidural, obviously we want to make sure they can feel their legs and stand up and walk, okay? If they've not had an epidural, they still may have some effects of laying in bed for a long time or whatever. So we want to make sure their blood pressure is a satisfactory reading. And then have them sit up for a little bit. Just have them kind of adapt and see how they feel. And then help her stand up. If you're really concerned, have a nurse with you. That's how you do it, to stay safe and to keep her safe. That way, if she does go down, the two of you assist the patient down very carefully and slowly. And then ambulate alongside her and provide support if needed. They usually do pretty good, but it's many variables. So I frequently ask how her head feels. I frequently say, "Are you okay? Talk to me. Do you feel dizzy? Let me know how you're feeling." I always want communication to happen, because if she stops talking to me, I got to think something's wrong. And then you stay close by. This is the time, sometimes we stay right in the bathroom with them when they urinate. You get kind of used to that in OB. Like, okay, whatever. We just help them and help clean them up, help get the peri pads changed. We're all girls, most of us. I know, guys, I know some of you are out there. This is a girl thing. This lady, look at her stretch marks there. Stretch marks are caused by stretching of the skin, how rapidly it stretches, but some ethnic groups will stretch more easily than others. There's nothing you can do about it. It is what it is. Yeah, they like to put, I don't know, ointment and cream on it. That's fine. It's not going to hurt, but it is what it is. But these stretch marks will eventually fade with time. They'll get to kind of silvery lines. That may take up to a year. The linea nigra, which is this brown, see the linea nigra, the brown, that will fade. That'll go away. As the hormones of estrogen and progesterone decrease, these will all resolve. Diaphoresis is common, as you know. They're sweating, well, you now know, because it's another way to excrete fluid. And hair loss. This is an interesting one, and one that I experienced, and it was really scary, guys, because you're sitting there you're brushing your hair, you wash your hair, you brush your, and it comes out in clumps for me. Not everybody will do that, but it came out in clumps. It was creepy, okay? It's like chemo, but I didn't have chemo. It was really bizarre, and it really was creeping me out. I finally went on birth control pills for birth control, and that fixed the problem. So we can reassure these women that being on some hormone therapy will help fix that. It's just, I didn't realize how creepy that was till it happened to me. The estrogen and progesterone levels will drop quickly. The placental hormones will decline rapidly. All the stuff is going out. The prolactin levels will decline within 2 weeks if they do not breastfeed. Prolactin is the hormone of breast milk and let down and all that. So if they're not breastfeeding, it'll take a couple weeks for the body to adapt to that. The insulin and glucose return to pre-pregnancy level within the first week. 70% of gestational diabetes will recur with subsequent pregnancies, and then 50% of your gestational diabetics will develop diabetes within 5 years. This is very important to share this information with your patient, because they need to know that they're at high risk, so they can be watching their nutrition and keeping their weight in control. I kind of skipped the weight loss because, yes, you lose weight. You lose about 20 to 25 pounds initially just because of the baby, the fluid, the placenta, all that coming out. Immediately, you're like 25 pounds down. And then it's variable. A lot of fluid will come off in the first couple weeks as the patient diureses. And it's important to warn these women. This is another thing I want to mention. What happens after they deliver, they are urinating a lot. Well, then they get home, and what will happen, the fluid shifts from the bloodstream into the tissue. Remember that 50% more blood, how it gets out is it shifts from the stream into the bloodstream into the tissue, and so they'll swell up again. They'll swell up more. And after about 2 or 3 days, we'll get a phone call and say, I am really swollen, and just reassure them, keep drinking water, keep your feet up. We review other symptoms of preeclampsia with them, but reassure them that that's your body excreting all the fluid. It will eventually go out your kidney and be gone. So that one's something to prepare your patient for, because otherwise it can be quite a surprise when they get home and they think they should get skinny, and instead they get fat for a bit. Oh, the breast crawl process. If I can find this video, I'll have Mr. Oliver load that into the course, because the breast crawl is really fascinating. That's where the baby literally crawls up to the breast without mom's hands. I mean, they will find it. So there's a great video on that. I'll see if Mr. Oliver will include that in the course so you can watch it. And if you even want to Google breast crawl video, you probably could find it. The first few days they'll have colostrum. Colostrum is very heavy in calories and fat. It's thick and creamy, and it is the perfect first meal because it's got the calories the baby needs. It's in a small quantity. They are not going to get like 4 ounces of colostrum. So what they do get is high in calorie, high in fat, and it's the perfect first meal for the baby. The breast milk itself will generally come about 4 to 5 days after childbirth. That is another variable thing. Some women it'll come in 2 or 3 days. We do encourage lactation specialists, a visit by the lactation specialist for anyone who is breastfeeding, especially if they are very afraid or don't trust their bodies to do it right. Or if they have special circumstances, their baby is in the NICU or something, we want them to have the best start possible with their nursing. So fortunately, we have these wonderful lactation specialists nowadays who that is their job, is to help promote confidence for the mom and get them on the right path and have a plan for however going back to work, how do I deal with that type of stuff. Reglan, metoclopramide will stimulate the hormone prolactin. So some women who say they don't have the letdown reflex, putting them on Reglan may sometimes help that. Engorgement is the process of swelling of the breast tissue due to the increase in blood and lymph supply as it's getting ready to be a lactating organ of the body. Yes, the breast is an organ. Weird, but it is. But it's getting ready to lactate as it swells up to fill with milk. And engorgement is caused by either not breastfeeding or not breastfeeding enough, or breastfeeding is ineffective. We're not getting the breast emptied, so they just get so painfully engorged. That's when the women will want to quit breastfeeding. That's why we need those lactation specialists. Engorgement is relieved by frequently breastfeeding and taking warm showers and putting warm compresses on before breastfeeding. And it's the eating that relieves the pressure and it provides the comfort. If someone is not breastfeeding, they're going to get engorged to different varying degrees depending on the woman and her hormone levels. But if she's not breastfeeding, what's advised is to wear a tight supportive bra, put ice on the breasts, and avoid stimulating the breasts so that it's avoiding getting more breast milk created. To suppress lactation and relieve engorgement, that's supportive bra, and believe it or not, red cabbage leaves. It pulls fluid off and helps relieve some of that discomfort. Breast comfort relieving engorgement is to breastfeed frequently with the warm shower or hand express milk. But realize if you do that, if you express milk manually, your body thinks it's got to make more milk. So then it'll still keep making too much milk. So if you just breastfeed, the body will adapt to the amount of milk the baby needs. So it won't over make milk, but it takes the patient to have patience to go through that process of letting it figure out how much milk to make. When we assess breasts, we want to look at their milk supply, see if they're having dripping of milk from the nipple, and or is it a thick colostrum, the thick yellow colostrum, or is it the more watery, milky looking milk coming out? And are the nipples intact? Do they look like they're have cracks or problems with where the baby has sucked so hard that they've interfered with the integrity of the nipples? And that's when we use lanolin cream, different medicines on the different creams on the nipples to help protect the integrity of the skin. But we have to assess that for bleeding nipples. Okay, for the woman who is not breastfeeding her newborn, which measure would be most appropriate to relieve engorgement? Which one would you tell her to do? Should be able to figure this out from what we just learned. We will tell her to put ice on to help decrease swelling. Manual expression, she's going to make more. Stimulate the nipple, she's going to make more. Warm shower, she's going to let down and make more. Let's put ice. The typical assessments to do in that postpartum period in the first hours, every 15 minutes. Right after delivery, we check every 15 minutes. During the second hour, every 30 minutes. And then during the first 24 hours, every 4 hours. And then it's every 8 hours after that. And if you know normal, you will recognize the abnormal. And if you know physiological changes, you know what is causing those abnormal findings. The post-op C-section assessment. Does a reason for the C-section pose an increased risk? What is your gut feeling? If she was C-section because she pushed for 3 hours and the baby wasn't coming out, putting a patient at more or less risk than someone who came in breech and it was a scheduled C-section and they did the surgery within an hour. Yeah, the one that's had to push a long time, she's at an increased risk for infection and hemorrhage. Okay, so again, know the reason for the C-section. In the recovery room, we do their vital signs, pulse ox, check the dressing, get the post-anesthesia score, which is a sheet they use to determine the patient's ability to move their legs or whatever, urine amount and color, and then the bubble E, which we'll go through in a minute. That's the actual postpartum check. We also get them to do skin to skin, and if they're going to breastfeed, do breastfeeding in that postpartum, in the post-op, post-C-section recovery room. Skin to skin is really important. And while dad is waiting for the mom to come out of the OR to be in the recovery room, he can do skin to skin with that baby because the baby will come out before the mom in a C-section. So the baby will be with dad and he can do skin to skin. I don't think he can breastfeed though. Sorry guys. All right, then when we admit them to the postpartum unit, after they have stabilized in the immediate post-op period, then they get their vital signs again, blood pressure, check the dressing, check the urine. Again, we do the whole thing with these parameters of every hour times 4 hours and then every 4 hours for the first 24. Always monitor for pain, tenderness in the abdomen. Reposition them in bed, but delay ambulation according to unit policy and client status. And I know I said earlier we want them up walking to prevent decreased peristalsis, but we do have to go by unit policy and make sure it's safe for them to do that. And we monitor them for itching, pain, and treat accordingly. Reasons to call the provider would be if the temp is over 100.3, heart rate's over 100, respiratory rate's greater than 20, or you got that blood pressure going up or low, either one. And you're going to have protocols on the unit, but we're looking for those vital signs that are normal and stable, and if they aren't, we need to be alert and make sure we're not missing something. If they have continuous pain that cannot be relieved with medications, let's say you've given a post-C-section that didn't get an epidural, you've given her narcotic and it just didn't hit the pain. You need to call anesthesia for one and surgeon for another. Urinary output should be over 30 mils an hour. Remember, they should be starting to diurese, and if they're not, we need to make sure they're not going into preeclampsia. And then about their bleeding. If they have a large amount of lochia twice or it smells foul, got to call. Psychological changes. The parents, especially first-time parents, feel very vulnerable. Dads especially are like really scared to hold newborn babies because they think they're going to break. These babies are very flexible and forgiving in themselves, within reason, of course. Nurses have a great opportunity to help the woman learn, grow, gain confidence, help the dad as well. Remember, we're dealing with a family unit now, and each family unit member is very important, and we can help them develop into a very functional unit. For women who have delivered, there's 85% chance that they'll have the baby blues. Now, that is not psychosis or depression. It's just like, ugh, I can't believe it's over. Just realize they've gone through a lot. They've had the baby shower. Everything was exciting. It's kind of like Christmas. If you are a Christmas celebrator like I am, you get all that stuff, you get all ready, and then Christmas is over, and you're like, now what? People have gone home. It's just me and this thing that won't stop crying or sleep. So they're going to have a little bit of postpartum blues, and that's normal. It should resolve within a week, maybe 2. But if they are still having problems by week 2, after week 2, then they need to get in. And it may be the significant other that notices, honey, we need to get you to the doctor. You're something not right. Because we can treat it as long as we know about it. And the mother may not be the one to catch it. It may be the partner that catches it. Okay. So remember, the moms are going on no sleep. They're exhausted. There's so much to do, whether you're breastfeeding or bottle feeding, it's just constant. And there's just less time for yourself. It's been all about you, and now it's about the baby. It's a switch. I say you, the patient. Bonding versus attachment. Bonding is where there's a close emotional attraction to the newborn, and it develops in the first hour after birth, and it's unidirectional. It's from parent to infant. The infant is like, where the heck am I? They're trying to figure out, what is the light? What is this noise? What's going on? So the mom, the parents are actually bonding with the infant. But then attachment occurs when the infant starts attaching back. They start realizing, this is my life support. I rely on this person. I rely on these people. These are the ones I can count on. So that's where attachment occurs, when the infant's reactions get involved. Let's see, problems with attachment. Ideally, have a happy, positive experience that is highly anticipated. That is the ideal. We all want that. That's what we would sign up for. But the reality is, there are phases of development that we go through as mothers in particular. And it's Rubin's maternal development theory. Initially, there is the taking in phase. It's very passive. It's where you look at your baby and you're in awe of this child you created. This is really my child. You're in awe of the responsibility that has just entered into your life. You're in awe. You're taking in. But then after about the second day or third day, you start going, well, I can do this. Let me do the bath. Let me wash my baby's hair. Let me, I want to change all the diapers. That's when you start developing that ability to take care of, and you start developing confidence in yourself as a parent. The parents do. And then there's the letting go phase, and that's where you say, okay, I got this. And that might not happen for several weeks, okay? But it's like, okay, I don't have to be on pins and needles. I got this. It's also knowing who your support system is. That helps with this letting go phase. If you can let go and realize, my honey's got my back, or my mom's got my back, or somebody's got my back, you're able to get there quicker. All right. The partner also has adaptations to go through, and they're going to struggle to balance personal and work needs. Now, if the dad's lucky, they have a program where he works, and I say dad, I know there's all kinds of couples out there. Don't get on me. I know that. But the partner may not have the ability to have some time off. Hopefully they have a week or 2 of vacation time if there's not maternity or, what do they call it, postpartum? I don't know what they call it. But anyway, some workplaces are now allowing the partners to have that time at home with the baby, which is great. That's really what it needs to be. But not every employer will do that. So those partners are going to be balancing the personal and the work needs. They want to be home, yet they need to be at work. Somebody's got to earn the dough still. They're going to do a lot of watching, taking in, kind of like they might even be thinking about college. How do I save for that? I mean, we jump all over the place, don't we? And it's not just the partner, it's our own selves, but that tends to be what we do. And they have a 3-stage role development process. Expectations. What do they think life will be with the new baby? What is it to have a newborn in the house? Then reality sets in. Okay, that's not quite what happened. This is the reality, and I want to be more involved. My wife's not letting me do anything, or my wife won't do anything. It could go either way. So that needs to be balanced. And then that transition to mastery where they say, okay, my wife's having a hard day. Honey, you go to bed. I will take care of the baby. I'll feed the baby and get to put the baby down. That comes with time and confidence building as well. Emotional status assessment in the postpartum period. I think we tend to kind of do this subconsciously when we're taking care of our patients, but in a maternal newborn situation, it's important to keep it as a conscious level where we're really watching how is this couple doing with the newborn. Is the newborn safe with this couple? Not everybody's safe to take a newborn home. And if that's the case, you need to be the one to identify it early. When you go in the room, is the baby always in the crib on the other side of the room, or is the baby right next to mom? Or do you go in the room and the baby's sound asleep laying next to the mom, laying in bed with the mom? That's not good for a newborn. They can get rolled on. And so we need to take in all that information to assess that this is a safe environment for the baby and a safe method of taking care of the baby. We also want to know how independent these moms and dads feel. Some are very comfortable. If they've had 2, 3, 4 kids, they're going to get real comfortable. And then new parents are going to have some level of needing to have guidance. And that's what we need to assess for and help them with. The energy levels. Is mom so exhausted? And if she is, let's do some lab work. Let's see what's going on. Do they have eye contact with the infant? Like I said, are they on Facebook every time you go in the room and the baby's over there? That's not healthy. What is their comfort level with the infant? Are they able to swaddle the infant? And it doesn't have to be professional swaddle like your nursery nurses do. You guys, I don't know how the nursery nurses do that. They're all tight like a football. No, but do they swaddle the baby, and is the baby going to stay safe? What are the sleep and rest patterns? Is mom getting any sleep? And then watch for those mood swings and difficulty adjusting. Many cultures, this is interesting, many cultures consider the postpartum period as a cold period, literally cold. And so the mother must balance with warmth. And so if they drink warm tea, they'll drink hot tea to offset the cold period. That's why giving a mom cold beverages is not going to go over with this cultural group. Okay, and the hot-cold beliefs are common with Latin Americans, African, and Asian peoples. Some cultures have the mom, be confined for a month, and that's not a bad thing. The more these newborns with non-mature immune systems are exposed to potential infections out in the world, the higher the risk of getting infected. So I don't think the 1-month confinement is a bad thing. I think more of us need to do that. And when I say confinement, it doesn't mean the mom doesn't get out. It means the baby kind of doesn't go too far, too many times around too many people. I recently read of a story, a very, very sad story of a woman whose baby was out with family. It was in the family home of extended family, and somebody kissed the baby on the head, and the baby got herpes and died just because of the person with the herpes on the lip didn't realize she had it, and the baby got it through the brain, and the baby died. This should never happen. Okay, so while confinement is kind of a tough term, I think moms should at least limit the exposure of their infants for at least a month or 2. Okay, here's a question we didn't talk about, so I'm glad this question is here because now we will talk about it, so you'll know. During the first 24 hours postpartum, a slight elevation in temperature is considered normal. Is that true or false? If you said true, you would be correct. The elevation in temperature is probably a result of fluid loss during labor, and they get dehydrated. When you're dehydrated, your temperature goes up. So that's why it's really important for these women to drink a lot of fluids. Okay? With the infant, okay, we're going to talk more about the infant when we talk about nurse the infant, which is not today's lesson. But they are going to get vitamin K to help promote blood clotting at the first hour of life, erythromycin in the eyes to prevent eye infections, and a hepatitis B vaccine to start that 3 vaccines. The first one's given before discharge. We do have to get permission, consent from the parent for the Hep B. These other 2 are standard, and the parents, yes, can refuse, but we hope they don't because there's very legitimate reasons to getting those 2. The maternal, if the mom is Rh negative, she may need RhoGAM. RhoGAM will help prevent the RhoGAM sensitivity for future pregnancies. And if she is Rh negative and the baby is Rh negative, she does not need to get RhoGAM. It's only if the baby is Rh positive. If they do get RhoGAM, this is vital. Teach need for contraception for 1 to 3 months. Because if they get pregnant when the RhoGAM is at its highest level of activation, the baby can get the problem of German measles. Okay, so to avoid that, it says 1 to 3 months. I always told my patients 3 months. I erred on the side of if I say 1 to 3, they're going to 3 weeks. They're going to do no. So I always said 3 months. But just so medically you know, they need to be protected for the first 1 to 3 months. The Tdap check with current CDC recommendations for frequency. That is most of the moms will have had that already. If not, they need to get it before discharge. A little bit more about the Rh negative factor in the RhoGAM. RhoGAM is given to moms to prevent sensitization for future pregnancies. And the process by which that is done is that at birth, the infant's cord blood is obtained and sent to the lab for ABO-RH evaluation. If the infant's blood type is Rh positive, we would need to draw the mom's blood for RhoGAM study. Understand that RhoGAM is a blood product, so it has to be typed to match for moms. Once the RhoGAM study has been done, the blood bank will call when it's ready. And it says a unit, but it's just a shot, just a little shot given IM within 72 hours of delivery. And then we document that it was given. Nursing management. Let's see, we want to promote nutrition. The needs for the breastfeeding mom are greater than the bottle feeding mom because the breastfeeding mom's eating for her and her baby. She may discover some foods are not tolerated going around a second time with the baby. For example, chocolate is one that maybe the baby won't like as it's recycled into breast milk. Coffee, different items. Be sure that they know that if they drink alcohol, that will go to the breastfed baby. So the breastfeeding instructions are really specific to the mom's method of feeding the baby. They should plan on having meals that don't require a lot of prep for a while because they're not going to have a lot of time. It's quick and fast and yet healthy. Eating a high fiber diet will help because that promotes helps prevent constipation and promotes moving the bowels and comfort that way. And drinking a lot of water is vital, 8 to 10 glasses a day, especially if they're breastfeeding, okay? We support them whatever their choice. I know there are militant breastfeeding groups out there. My militant thing is feed the baby, period. Yes, breast is best. I will sign up for that slogan any day, but not everyone wants to breastfeed, and these women need to be supported with their choice and help to understand proper bottle feeding technique. So yeah, it's really an individual choice, and our job as nurses is to support them and teach them whatever they want to do, teach them how to do it properly. Pregnant and lactating client education. Medication only when absolutely necessary. If they need antibiotics, yes, they can usually still breastfeed. Smoking, alcohol, limit your caffeine. Again, smoking's always bad, always. Alcohol is some will get to the baby. If you have a glass of wine, one glass on a Saturday night, you're not going to harm your baby, but limit it, very much limit it. Same with caffeine. Avoid herbs because, in this day and age, we all these herbs and stuff. Got to be careful. We don't know the effects on the fetus of all these herbs, and definitely avoid illicit drugs, not only for the baby but for yourself. Encourage them to eat in a healthy manner, eat healthy foods, exercise, sleep well, avoid stress. Boy, we all should do that, whether we had a baby or not. I think we're all having trouble with that. Alcohol passes through the breast milk. Its highest concentration is at 30 to 60 minutes. So if you wait 2 hours, you're probably cool. And if we need to help them quit smoking, let's do it. Mom and partner, quit. Good time to do it. This is a pyramid plan for moms. I'm not going to read through it, but if you need a reference, this is a great reference for what moms should eat and how much of each per day. Okay? And then you've got breastfeeding only and breastfeeding plus formula. You notice they don't have bottle feeding on here, but the goal is healthy. There's several theories of attachment and becoming a parent, and the one that is probably most common or referred to very frequently is Mercer's 4 stages to becoming a parent. And these consist of these anticipatory, formal, informal, and person. The anticipatory stage of adaptation is that where they're taking in while they're pregnant, they're watching other moms, they're kind of trying to wrap their head around the fact that they're going to be a mom, and they accept the fetus as a separate individual. They're starting to realize, okay, this isn't just something inside me, this is a human inside me. And they start to fantasize about the new baby. Expectations are learned during this stage by looking to others. Other moms are very important to women in the anticipatory stage during pregnancy. The formal or role-taking stage begins when the baby's born, and this is where this is where we as nurses can make a big difference. We can help them adapt that role-taking phase, and maternal behavior is learned and replicated in this stage. So they can take in videos. They want to learn. They go to the classes offered in the hospital on how to take care of the baby. Very important. The informal role-making stage begins as she's home and she's starting to develop the maternal role to fit based on her personal history, how she was raised, what are her goals for the baby. She may want to be completely opposite of how she was raised, but these decisions are in the role making, the informal. I'm creating who I am as a mom. During this times when she's learning infant cues and develops her own style of mothering. And then the final stage is the personal or the role identity. And that's where they really integrate mothering into their self-system. It's internalized. She views herself as a competent mom. She has confidence in herself, and she's learned some tricks of the trade that work for her and her infant. There are, of course, factors that affect attachment. The educational level of the mom, the desire to or to not have the baby in the first place will hinder attachment. How involved are the social structure? Does she have a really reliable partner, or is he kind of a jerk? Big difference. So there's a lot of factors that will affect that. Critical attributes of attachment are the proximity, the contact, emotional state, individualization, reciprocity, how are they viewed by their significant other, and then how committed are they to becoming a parent. So it's important to really kind of pay attention to all these aspects, just be aware of them when they're in the hospital. They're going through a lot. And then you have the grandparents and siblings. There's a lot of variables that come into play. And, you got the grandparents that are awesome, and then you have the grandparents that try to tell you how to do everything. Well, that is obviously going to interfere with these Mercer's 4 stages. Don't tell the woman how to do everything. These grandparents hopefully will take a grandparent class, which they do have, to say back off and support her making her decisions. Teaching topics in the postpartum period. We've we've discussed all of these, I believe. Pain and discomfort, the immunizations, what to expect for the baby. Nutrition, we've discussed that. Baby nutrition will come in another group of slides. Activity and exercise and how to balance that with rest, getting adequate rest. Lactation and what to do if you don't want to lactate. Depression and the difference between postpartum blues, postpartum depression, and postpartum psychoses. Sexuality and contraception is a big topic. Our sexuality as women changes when we're a mom because moms don't have sex. Not true. But we have a whole different role. We're exhausted. Our baby is our focus, and it's important for our spouses to understand that you will become important again. Support your wife in this transition. And contraception, let's get a grip on how often we want to do this, right? It's prime time to talk about contraception. Follow-up would be a telephone call, outpatient or home. Different facilities will have different policies, procedures, ways they do that. The physician's office may do some of that. So that follow-up care is maybe more important, especially important with someone who's depressed or have breastfeeding problems. You know, if they've had some trouble, the follow-up becomes very, very important. Okay, ovulation, return of menstruation, yes, it happens. It is the interplay of all the hormones that have been so active in our lives as pregnant women. The non-lactating woman, her period will start within 7 to 9 weeks after birth in general. That doesn't mean she can't get pregnant on week 2. Okay, she can. But generally, the menstruation will occur 7 to 9 weeks after. Lactating women depends on breastfeeding frequency, so they say, and duration, anywhere from 2 to 18 months. And I say so they say because I breastfed a lot. No, I didn't get pregnant, but I breastfed a lot, but at 6 weeks I had a period. Like, what the heck? So yeah, anyway, so it's very individualized. That's what's important to know. And the other thing that's important to know, you can still get pregnant while you're breastfeeding, mother. Breastfeeding may cause amenorrhea or menses may occur shortly after delivery. Either one, we're all different. It depends on the hormones. I'm not going to say really much about contraception because I know you've had it you've had contraception as a concept already. With newly delivered moms, yes, they can still be on the birth control pill. It would be we like to start those before they have their first period. That way we know they're not pregnant. And for someone who's breastfeeding, they can use progesterone-only pills that will not limit their breast milk. Estrogen-added pills may cause a decrease in breast milk supply, so we don't want to give them that. The implant, Norplant, under-the-skin ones, those are really great for postpartum moms. Injections, the Depo-Provera every 3 months is another great method. That's really a perfect one for breastfeeding moms because it's progesterone only. They get their shot and they don't have to think about it for 12 weeks. The IUD, that is not going to be inserted until they're at the doctor's office for their 6-week check because if they put it in right after delivery, that goes in. Remember, we have the cervix and now we have this little os that's kind of open. So if they put an IUD in there when the cervix is still, the os is still kind of open, it could fall out. So wait till 6 weeks and then they put it in. They have to use another method of contraception until then, condoms. Emergency contraception, the morning after pill, that's possible, but that increases risk of blood clots, so I don't really recommend it. Plus, if you're breastfeeding, you don't want to use that. Vasectomy is another very viable contraception method. And the thing that's important to know with that is it is not considered effective right away. You got to use condoms for at least 3 months to make sure the sperm count has time to decrease. Natural contraception, I kind of call this Mother Nature's way of giving you another baby. Yes, it is quite possible to use natural contraception to determine when you're going to have kids, but it requires a really regimented, someone who really pays attention. So if you're that kind of person, if the mom is that kind of person, just make sure she understands how to do it, and then it's up to her. Discharge teaching, we want to teach the moms about self-care, medications, activity, and any problems. Those, you get home and you start having a lot of heavy bleeding again, or you get home and you start to see spots before your eyes. We're talking preeclampsia signs and symptoms. You're going to swell up, but then it's going to go back down in about 3 or 4 days. Give it time. All that discharge teaching that we've done throughout. Infant care, feeding, safety, and problems. We're going to cover those in the newborn PowerPoints. Before going home, mom must be stable, fundus must be firm and midline. Okay, so this brings me back to one thing I did not tell you guys. Shame on me. The fundus, I've told you, should be firm. What I forgot to mention was it needs to be midline. It needs to be in the middle of her abdomen. So if we've got an abdomen here and the fundus is over to, and here's her belly button, and we have a fundus that's over to her right or her left, that's not where it should be. It needs to be midline. And what's most likely causing that is a full bladder. So if you check a patient and her fundus of her uterus is up and over to the right or left, displaced, have her go to the bathroom and then recheck her. It should be midline when you're done. Okay? Also, no signs of infection, and the surgical incision is normal. Ambulate without trouble. That she's eating fine, she's able to take care of self and baby, that she has help at home. We want somebody there with her. And the mom needs to be aware of possible complications and when to call. And also the significant other. I would have that person involved as well because, as I said, postpartum depression is often caught by the partner, not by the patient. Follow up, make sure they have the phone numbers for their providers, the appointment schedule for the newborn, what's anticipated. The mom will be seen in 4 to 6 weeks, 4 weeks for surgery, a C-section, 6 weeks for vaginal. They might have telephone follow-up, home visit. What emergency numbers? Make sure they have poison control by their phone, okay? Because at home now they got a baby. So, and make sure they've got poison control numbers posted where they can see them. Postpartum home care. If they have a visit by a home care nurse, home health care nurse, they would want to assess all these things. How's the mom doing, the baby doing? You know, if they go home so early, some women will need that visit like in a week or less, 3 or 4 days. If the baby's been nursing kind of fussy like, you might want a home health person to go out and check. See how the baby's eating. Kind of assess the environment, that it's a safe environment. The parents are dealing with stress okay, because it's going to be stress. So are they dealing with it okay? Emotional needs, warning signs, preventing problems. Again, that's just a thorough assessment at home, okay? Well, if you have questions, ask your professor in class and write them down. Thanks for listening. A lot of information again, so thanks for listening.